Good afternoon, everyone. We are so very grateful that you have chosen to tune in this afternoon to the Ebenezer Seventh-day Adventist Church Health and Temperance Summit. We are so very grateful for you taking the time out of your busy schedule to join with us today. We have a very powerful presentation that'll be brought to us by Dr. Paul Alphonse. He'll be introduced to you in just a moment. But for those of you who are new to us, pretty much on a monthly basis, we are providing both health and temperance talks, and we also have a life enrichment series that we produce in order to be able to help make your lives richer. So we are grateful for the opportunity to be able to serve you. We're grateful that you've chosen to be with us today, and we're so very grateful to our panelists that are here, and Elder J. James, who is an educator in the Thompson High School here in the CSRA, and then Dr. Paul Alphonse. Again, we'd just like to say welcome. Thank you for choosing to be with us and participating with us today. And to our host, our pastor, Pastor Lauren R. Hydenet, and our Health and Temperance Director, Dr. LaShonda Hurst. Again, we're so very grateful for your leadership and your role in ministry. So without further ado, Elder James, would you be so kind as to introduce us to our speaker for today?
Most definitely, most definitely. Dr. Paul Alphonse has been a urologist with WellStar since 2013. He graduated from the University of Central Florida with a BS in biology and received his medical degree with high honors in research from the University of Florida. That's the University of Florida College of Medicine. All right. So he completed his residency in urology at the Scott Department of Urology at Baylor College of Medicine in Houston, Texas. He then completed a laparoscopic fellowship in Atlanta. So if you think he doesn't know what he's doing, he knows what he's doing. Dr. Alphonse has served in several clinical committees for various hospitals in Midtown Atlanta market, and was in turn named the Chief Urology at Piedmont Hospital in Atlanta. Dr. Alphonse also served as the past president of the Atlanta Medical Association. He's a member of the American Urology Association and Endocrinology Society and the Medical Association of Georgia and the Atlanta Medical Association. Wow. He has his certification from the American Board of Urology. Now, Dr. Alphonse grew up in Orlando, Florida, and he enjoys spending time with his wife and his sons. And in his spare time, he enjoys the Georgia outdoors, playing and watching sports. Now, one other thing I want you to know that he is fluent in 3 languages: English, Haitian Creole, and Spanish. All right. So without further ado, I present to you Dr. Paul Alphonse.
Thank you very much, everyone. Before we get too far into it, I just want to thank everyone, Dr. Hurst, Pastor Hydenet, and the entire family at Ebenezer for giving me a brief opportunity to share a few pearls with the audience out there. The information that I'm giving today is near and dear to me simply because it is what I do for a living, but more importantly, it is a means of enriching, enlightening, and educating all of our men. And so this is something really important for both on the men's side and the female side, because we know all too well that sometimes as men, we are slow to seek help, and sometimes we have to trust our better half to point us in the right direction. But before I get too far into it, let's just take a brief moment for bow our heads for prayer, and then we'll go ahead and get started. Dear Heavenly Father, thank you very much for the opportunity that all of us are here today. These words are not of myself, but these words are from you. Help them to bless at least one. Amen. Okay, so the information that I'm giving you today is very well focused. It is pretty much to talk about what's going up down there. The prostate in and of itself is something that is quite easy and difficult at the same time. So what I want to do is to give the audience a little anatomical information to understand the male urinary system. We're going to talk about prostate enlargement, which is called benign prostate hypertrophy. And we're going to talk about a number of different ways to treat it. I do have a video clip, and I'm going to trust and believe that when I hit the button, that the video clip will work. And so we're going to leave the rest in God's hands, and let's see how this works. So first thing that we're going to do is talk about what enlargement of the prostate is. We're going to talk about some terminology. How do I go about evaluating it? When you come into my office, what do I do? There's not like a secret sauce, if you will. This is pretty cookie cutter. We're going to talk about some medical ways of treating it. And when the medical ways do not work, some surgical ways of treating it. And then we're going to come to some conclusions and open up a question and answer session. So when we talk about benign prostate hypertrophy or prostate enlargement, you will commonly hear the word thrown around called BPH. BPH is benign prostate hyperplasia, or another word of meaning non-cancerous enlargement of the prostate. And that non-cancerous enlargement of the prostate is one that can cause some significant irritative and obstructive urinary symptoms that doesn't happen when you're 12 or 15 or 20. But for the most part, once you start getting past age, let's just say 40, then things come to the forefront. And I call it the rule of tens. 40% of men age 40 and below will have some prostate enlargement symptoms. 50% of men 50 and above will have some prostate symptoms. Then when you get to your 60s, 60% of men and above will have some prostate symptoms. So you can see the older that you get, eventually all of us men will have some urinary issues. And bladder outlet obstruction, lower urinary tract symptoms, BPH, these are all different ways of saying the same thing. So this is just a little graph that says the exact same thing that I mentioned earlier. Starts roughly in the 40s, becomes really prominent in the 50s, and then as we get older, it becomes much more significant. We talked about this already, bladder outlet enlargement. There are a number of different ways to evaluate it, and we're going to talk about that now. So, prostatism. Prostatism or BPH, how do we evaluate that enlargement? One of the things that we do when a patient comes into the office is ask some urinary questions. How difficult is your urinary stream? Do you feel that you're empty? Do you start and stop when urination? These are all really good classic symptoms that helps us to understand the severity of your urinary symptoms. And these symptoms in and of themselves are something that is written in a little questionnaire, if you will, called the International Prostate Symptom Score. And that IPSS is a score that can be as high as a 35. And that's a way for us to get a good baseline in terms of how bothersome are your symptoms to you. And then as we put you on medications and come up with some treatment, then as we go forward, we'll do the same questionnaires over again. And then we can see exactly how low that number gets. And then we could see where we were, where we are, and obviously where we want to get to. But there is a paradigm, if you will, and that paradigm is in the 60s and 70s when people started talking about prostate enlargement. It was the classic definition of a big prostate, and big prostate cause a blockage, and that blockage prevents you from urinating. But what we really had an opportunity to know is it is not necessarily about the size of the prostate, because even small prostates can cause problems as well. So we have kind of morphed into, if you will, of just looking at people who have big prostates, but people who have a contracted prostate, and that contracted prostate can irritate, if you will, your ability for you to urinate. So if we look at the normal prostate here, this right here is your bladder. This small little acorn segment beneath the bladder is the prostate. Normal size is anywhere between 25 to 30 cc's. This is where you can get some prostate enlargement. And what this right here is trying to show is that the urine channel that goes through the prostate can get strangulated. And if it gets strangulated, it can cause patients to have difficulty for urine to go through. What we've seen is that even in some of these small prostates, that there are these little receptors, and these receptors are called alpha receptors. And if these alpha receptors have been overly, if you will, stimulated, it can also cause that squeezing sensation that makes you feel very uncomfortable, like you haven't fully emptied yourself. So the evaluation in and of itself, the classic, bring you in, get a history from you, find out how long the issues have been irritating you, get a urinalysis for us to check and see if you have a obvious urinary tract infection or if you have other issues going on. This right here is the symptomatic score we talked about, where the IPSS, or the International Prostate Symptom Score, if that number is less than 7, it's considered mild. We really don't do much about it. If it becomes greater than 8, from 8 to 14, if you will, that's what we consider moderate to severe. And then once you get past, if you will, 17 and above, that's where you started getting to very irritated symptoms, where we look at medications, quickly move on to minimally invasive therapy. And if those don't work, then look at surgical alternatives. So things that we also need to look at is, in addition to the symptom score, there are some additional tests that we need. And sometimes those tests are getting ultrasounds to see exactly how much urine remains in your bladder after you pee. So if you think about your bladder as this big funnel, your prostate is beneath it, and it's the gateway, if you will, that opens and closes to allow the urine to be able to leave. That gateway is closed. It's preventing you from being able to empty properly, and it's causing you to retain urine. So a way for us to figure out how bothersome those issues are is we have you go to the bathroom, empty your bladder out, and then we scan your bladder with an ultrasound to see how much urine remains. If you have anywhere between 25 to 30 cc's of urine, it's not bad. Once you start getting greater than 50 cc's, then those are some of the patients who start to get a little uncomfortableness, if you will, down in the bladder area. And then patients who have greater than 100 cc's are constantly either kind of pushing down in the belly area or loosening their belt because they feel like they have gas or they have something going on. And it's not gas, it's their bladder that's not emptying itself well. So they have a lot of irritative bladder symptoms. And then other issues that we will do is sometimes do little cameras to look inside the urinary channel, to look and see if there's something else, such as a bladder tumor, bladder stone, bladder polyps. There's a host of other issues, if you will, that could be going on. And so sometimes, depending on how unique your presentation is, we will do a little camera called a cystoscopy to take a look. And traditionally, we start people on medications, and when the medications don't work, we go into other surgical options, and we'll get into that a little bit later. This right here is the IPSS form that I mentioned earlier, broken down into 3 different categories. 0 to 7 is mild, 8 to 19, moderate in symptomatology, greater than 20, very severe, and this is what we use to monitor you. So the goal of therapy, what are we doing this for? We are doing this to decrease your symptoms. Symptoms such as frequency, urgency, sensation of incomplete bladder empty, starting and stopping, getting up multiple times at night. These are all the symptoms that can end for your missus when you get up 6 and 7 times at night, waking her up in sleep. So we're trying to make it well for everyone. We're also trying to decrease what we call your bother score and improve the quality of life. Yes, decreasing the prostate size tend to be extremely helpful, but we also want to see how we can improve your flow. If you think about a river or a stream, we want to improve your peak flow rate. So have you urinating very well. And we want to prevent a lot of long-term complications of your body retaining all that urine, because people can go into urinary failure. I have seen that multiple times. So when we look at different ways to treat the prostate enlargement, the cornerstone, if you will, is something that we call alpha adrenergic blockade or alpha blockers. There are others, which are 5-alpha reductase inhibitors, and I'll go into that. And then we have other things such as anticholinergic therapy, Detrol, Ditropan, and others. And I'm going to show you examples of each one of those medications. Everything on this screen that you see right here are examples of alpha blockers. Cardura, this is Alphazocin, Flomax, Rapaflow, Jalin. All of these are different variations of the same thing, which is these medicines block the alpha receptors in your prostate. Those alpha receptors are the ones that, like I said, cause the squeezing, if you will, of the prostate muscles. And if we can block those receptors, it relaxes the prostate and helps you to be able to empty better. Other type of medications, if you will, have different dosages. The Cardura can come in a 1 milligram, 2 milligram, all the way up to a 16. Flomax, if you will, comes in a 0.4 or 0.8. Alphazocin only comes in one type of pill. Rapaflow has a low dose and a high dose as well. And each one of them have their different selectivity, if you will, in terms of some of them work a little bit better than others. So it's not to say if one works for you, it's going to work for everyone. Every person has a medication that works best with their body chemistry. So sometimes we have to try different medications. So when is the indication for surgery? The indication for surgery is when the medications just do not work. You have a problem with enlargement of the prostate, we put you on the medications, try a couple of different medications, and if all those medications don't work for you, then we need to look for a surgical alternative to open up that prostate flow, because if not, then you can get into significant complications. These complications include kidney failure, urinary tract infections, bladder stone formations, and the thing that we really want to minimize is significant bleeding that can put you in what we call clot retention, meaning you get so much bleeding in the prostate area that blood clots develop and it clogs your urine channel. So what are the options that are out there? A lot. There is probably in the past, goodness gracious, I remember when I did my first research back in 97. I did my first research paper in tuna. This is one of the minimally invasive therapies right here, which is the transurethral needle ablation of the prostate. That's when I was at University of Florida. And they just thought that was going to be the end all be all to all prostate therapy. And as you can see, it has not. There has been so much more since then. Transurethral microwave therapy. There has been Resume, ProLift, Botox. Obviously, every single different kind of laser you can think of, holmium laser, PVP green light, and vascular laser therapy. There's electrosurgical option. The most common, which is called the TURP, or the transurethral resection of the prostate, or what I like to call the Roto-Rooter. I think it's very descriptive and people kind of understand. We go in there and kind of open things up to allow you to be able to empty better. And then there's old-fashioned open surgery, where we actually make incisions in the abdominal area to remove the certain portion of the prostate, when a lot of these other options are not ideal. And I'll talk. So if we were to go into some of the surgical therapy, we'll talk about the cornerstone, the TURP. The advantages of the TURP is that it's been around. It's been around forever and a day. It has great long-term data. The ability for you to be able to empty yourself with a forceful stream and not have any significant burning or stinging on urination once you pass that 6-month mark. These are extremely, extremely positive signs. The disadvantages is the prostate. It is a tissue that actually produces 75% of the ejaculation. So if I go in there and I carve out that tissue to remove that prostate tissue, it can impede your ability for you to ejaculate during orgasm. So this is something that I really drive home to my patients to make sure that they understand. If this procedure is selected, you are going to urinate and pee like you were 12 years old, but the ability for you to ejaculate like you are accustomed to, that is going to be forever changed. So for some people, that is a big deal breaker, and they truly, truly, truly look for other options, whether it's medications or minimally invasive therapies, before we have to go to this procedure. But this procedure is greater than 90 to 95% effective. Disadvantages, the retrograde ejaculation, that's the biggie. But of course, some bleeding can occur in patients who are on blood thinners, something called TUR syndrome, transurethral resection syndrome, sodium issues can occur. It's very rare with a lot of the new technology that we have today. You do have to have a catheter and traditionally a hospital, overnight hospitalization. In this day of COVID right now, we are doing anything and everything possible to minimize hospitalizations of patients. So where appropriate, patients are going home the same day. So what does this Roto-Rooter look like? This right here is a little pictorial that kind of shows you the prostate here, the lower portion of the bladder there, and we are literally carving the inside of that prostate open. It's almost like if you were to take an apple, pouring out the middle of the apple, making that channel wider for you to be able to pee easier. So that's what that looks like. And this right here is a intraoperative view of what the prostate channel looks like. This area is before we've done anything, and this down here below is after everything has been opened up, and this patient had a really good result. So now let's see if my video clip works. And to speed things along, I've kind of marked, if you will, there we go. All right, so in this video right here, the patient is asleep. Instrument is going inside the urinary channel. We're filling the bladder up with fluid. Now I'm looking inside the urinary channel, and all this obstructive tissue right here is what's blocking the channel. This dark area inside is where the bladder is. And I am using my electrocautery instrument to shave and open that area up. I'm pushing all the tissue inside the bladder for me to irrigate and remove that tissue at the end of the procedure. So after the procedure is over with, I've irrigated all the chips out. There's a Foley catheter that's placed afterwards. That Foley catheter is in place, stays in place for a week. We remove the catheter in the office a week later, and patients do tremendously well. All right. So in terms of how effective, the TURP is, you'll see averages anywhere between 88, 90 is what we've seen really in terms of how effective it is. It significantly decreases your IPSS score or the AUA score. Greater than 125% change in the flow of your urine, meaning If you were trickling urine before, when you pee after this procedure, it's going to be like Old Faithful. You're going to be able to really urinate and empty yourself out well. Now, I do drive home the fact that there is no such thing as a silver bullet in medicine. So even for some patients, we do have to reoperate. And that number is roughly about 15% lifelong, where 15% of patients who have this procedure, the prostate tissue will grow back again, and I need to go in there and open up the tissue. In terms of complications, clot retention due to blood clot that can develop, people who are on blood thinners, scar tissue formation or strictures, low but can occur. Transfusion, 7%, so 93% of the times patients do well, 7% of the time we do need to transfuse them blood. The TUR syndrome, which is the sodium issue we talked about. Incontinence, meaning the inability for you to maintain and not leak on yourself. That can occur in about 1.5%. And we already talked about the reoperation rate. So then other options, if you will, instead of going through your urine channel, doing one of the old-fashioned ways, which is called a simple prostatectomy. So this right here is a anatomical diagram. This right here is the penis area. This is the testicle, the pubic bone here. This right here is the bladder. This is an example of the surgeon's finger inside the patient's bladder. Incisions have already been made to loosen up this tissue. This is where the prostate was, and this is that big tissue that has been removed. And you can see the surgeon is inserting their finger in there and kind of going around, loosening up that tissue and pulling it out. This is another view of the exact same thing. This is a robotic approach, laparoscopic approach that shows the instruments that we use that replicate the same movements that we do by hand. This is where so we're looking into the bladder here. This is the tight area where the urine stream is supposed to go in. We've kind of scored around the prostate area, use our laparoscopic scissors to go around it, use this little suture here like a handle to pull on that tissue, and then keep working around that tissue until we pull it all the way out. And then these are some imbricating sutures that we use to help stop a lot of the bleeding. So 2 ways of doing it: an old-fashioned open incision, or the laparoscopic ports, which are these small little holes, if you will, that allows us to do the exact same thing, yet through small little holes. The simple prostatectomy, of course, has its pluses and minuses. The minuses of the simple prostatectomy: bleeding is an issue. That is something that can occur simply because of the amount of work that is being done to get the prostate tissue out. Injury to adjacent organs, meaning nerves, specifically the nerves that go down to the penis, which is the pudendal nerves. Those are the nerves that are very important in terms of erection, and sometimes in making the large incisions. Those are microscopic fibers that we don't see with the naked eye that can get injured. Similarly, the urinary incontinence, the dry orgasm we talked about because we're removing that prostate tissue. A dry orgasm can occur. Erectile dysfunction, stricture or scar tissue formation, and the reoperation rate lower than the 15% with the Roto-Rooter, but around 8% need to be reoperated. And this just basically says that it's extremely, extremely effective. We'll pass over that. So for patients who don't want to have a Roto-Rooter, patients who don't want to have an incision, what other options are available? In 2021, we have a lot available to us now. A lot of other things have kind of gone by the wayside. And so these are kind of the new and improved options that are out there. One is called the green light laser. Green light laser uses a laser that actually goes through the urine channel and actually evaporates, burns the prostate tissue away, making that channel a little bit larger. one of the attractiveness of using this procedure is, as again, patients get a little bit older, they tend to be on common medications, and those medications are blood thinners. Those blood thinners, for some patients, they really can't come off of it. They have bad heart disease or severe stroke issues, and the cardiologist or the neurologist do not want them to come off of it. We can actually do the green light laser on blood thinners, and so they don't have to come off of that medication. So this is what it looks like inside the operating room. This right here is the generator machine. This is the operator here. This is our screen that we look at, and this is that green light laser going directly into our isthmus here. So let's see how it works. All right. So the green light laser fiber, this is this little handle right here. And this fiber we're going to put through what we call a cystoscope. It has a angled fiber, so it doesn't come out at the tip, but it comes out at the side. And that's extremely important. So the patient here is asleep, and let me just kind of give you for orientation. The patient's asleep up here, the legs are up here, the urologist is in the middle, and this is the nurse or the surgical tech that's assisting. So as the procedure is being done, we are focusing the location of where the prostate and where the bladder is. And then once we enter the instrument, we're going to use that laser fiber, if you will, to burn away tissue. And as we're burning away that tissue, it's going to create a wider channel. So you can see here, this is the green light laser burning that tissue away. And the the laser fiber only goes a certain distance. So this is not something where it's going to burn all the way through the patient. It's at a very, very, very fine distance. And that allows us to have a lot of control so that we can manipulate how much tissue we want to burn away. And that allows us to have, as you can see here, a good before and after in terms of what the prostate tissue looked like before and what the prostate tissue looks after. You can see this retaining a lot of urine. Here, the patient is able to empty it a lot better. All right. Complications. Every procedure has pluses and minuses. The minuses with the green light laser is that bleeding can occur a lot lower, but it can occur. Because you are using a laser, there is some burning and cauterizing effect that occurs, and that can cause some short-term burning on urination. That burning does last for anywhere between 4 to 6 weeks, but it is short in duration in terms of giving you the complete relief that you're looking for. Retrograde ejaculation or the dry ejaculation, again, you can see a common theme here. That's something that can occur. Scar tissue formation can occur. Urinary tract infections are rare, but can occur. And the reoperation rate is about 4.5%. Microwave therapy. Microwave therapy is using a different way to deliver energy to that same location in the prostate. We've talked about electrocautery. We talked about green light laser. Now we're talking about microwave. So this is not the microwave that you heat up your food in. This is a microwave that's being delivered through a specialized catheter. And that specialized catheter has an antenna that's very, very short, and it gives radio waves specifically in the area of where the prostate is. So let's see how this works. We'll go back here. There we go. So the microwave therapy, the probe is inside the prostate. It is centered, obviously, from the generator machine. It has a fiber that goes through the cystoscope. Once that fiber goes through the cystoscope, then I specifically align where that fiber needs to be. short fibers for short prostates, long fibers for longer prostates, and everything in between. So we can alter, if you will, the degree of the radio images that we're giving. So let me fast forward here. This is the instrument. This is inside the bladder. This is the balloon. This is the active portion here. So this is the energy being given to the prostate. That microwave energy is approximately anywhere between 30 to 45 minutes is the delivery time. And when you give that treatment, a Foley catheter traditionally is left afterwards, and that Foley catheter stays in place to allow the patient to be able to urinate a week later. We don't remove the catheter immediately because we know that it's going to be a little bit of swelling before things settle down. It's pretty straightforward outpatient procedure. Patients are able to go home the same day with the catheter. That's the microwave procedure. The minuses with the microwave procedure, the swelling that I talked about, that swelling for people who have big prostates can be significant, and it can cause you to go into what we call urinary retention. Big fancy word that means the swelling in the prostate that normally goes away after 1 week, sometimes lasts 2 weeks, and we need to have a catheter in place throughout that entire duration and then remove the catheter 2 weeks later. Urinary tract infections are rare, but can occur. Of course, some post-procedural discomfort is expected. That retrograde ejaculation or that dry ejaculation, we've talked about that already, but that's a recurrent theme here. And the pain and discomfort, if you will, is everything we just talked about because of that swelling. And the reoperation rate's around 8%. So what else do we have? I'm glad you asked. We have something called the Resume procedure. Resume is using a different technology, vapor. So the same water vapor that you use, it is using essentially steam to cause shrinkage in the prostate area. So this right here is the generator. This is the prostate area. And I'm going to show you in the next other slide how that steam is delivered. We can skip over this area here. And this is a good spot. Oh boy. There we go. All right. Let's back this up a little bit. So pause this here. Prostate, bladder. This is all the tissue in the middle of the prostate that is causing that strangulation, if you will, of the prostate tissue. And this is what we're going to open up with the vapor therapy. So the probe goes in, the needle is deployed, the vapor is a 9-second burst of energy. And during that 9-second, it causes what we call crenation or shrinkage, if you will, of the prostate cells. An average prostate, we use 4 areas of treatment so that we treat both the left side and the right side to make sure that everything is appropriately addressed. The kicker, this is not something that happens immediately. This is something that causes resorption or shrinkage over a 3-month period. So this is not something that you will immediately notice a difference, but you can see here subtly over that period of time how that urinary channel opens up. So this is a very effective, minimally invasive way of opening up the prostate tissue. All right, let's move on. Now, one of the things that I have repeated almost with every procedure that I've talked about thus far is the retrograde ejaculation. And again, I mentioned that tends to be a huge deal breaker for men who do not want to lose that portion of their sexuality. The vapor therapy and one other is a very unique way of being able to treat the prostate, but this therapy will maintain your ability to ejaculate. So that's what changes. This is where technology and things have advanced to the point that now we have a therapy that's available that can shrink the prostate and not disrupt the ability to ejaculate. The retreatment rate, low, it's about 5%. And the most important thing is that all the thing that you're looking for in terms of decreasing of frequency, decreasing of urgency, sensation of incomplete bladder emptying, starting and stopping, or intermittency, all those things are improved with the resume therapy. Another option, Urolift. This as well maintains your ejaculation. Let's see how this works. The resume therapy, out of everything else that we've talked about before, we were talking about laser this, green that, all different types of therapy to use heat or some type of energy, if you will, to shrink the prostate tissue. This throws everything out the window. This doesn't use any energy whatsoever, but this uses a very unique type of approach to use implants and sutures, if you will, to open up the prostate tissue. And by opening up the prostate tissue, making the urine channel a little bit wider. And I'll show you exactly how that works. So the Urolift, again, outpatient procedure, minimally invasive, tends to be anywhere between 15 to 20 minutes. I've done it as short as 8 minutes on really small prostates. Patients rarely have to have a Foley catheter placed, but only in large prostates do we have to place a catheter. So how does it work? This right here is an example of the prostate. This is the bladder. This is the instrument going through the prostate area. The needle is deployed. It goes all the way through the prostate. It deploys an implant that's on the outside of the prostate. That implant hooks, if you will, the tissue, and then there's a second implant on the inside of the prostate. So it squeezes or it pinches the tissues together. And when you pinch one side and you pinch the other side, and you do that a couple of times on the top and bottom of the prostate, you can see how it opens up that urinary channel in comparison to what it looked like before. So let's see how this works. And I'm going to speed things up here. All right, orientation, bladder, prostate, instrument is going through the prostate area here. The needle is going to be deployed, 33, there we go, millimeters. Implant is on the outside of the prostate, suture attached to another implant on the inside of the prostate. Then we're going to replicate the exact same maneuver on the other side. Needle, 33 millimeters, implant on the outside, implant on the inside, suture holding the two implants together, pinching the prostate tissue. An average prostate will have 2 implants on the left, 2 implants on the right, for a total of 4 implants. Pretty neat. So this right here, that's the good before and after. And that is exactly kind of how it looks. All right, so now let's talk about it. So every procedure has its pluses and minuses. This one can cause a little bit of burning for a few days. The frequency and urgency is rare, but can occur. The bleeding is extremely minimal because, again, you're not carving, burning, cutting away any tissue. The pelvic discomfort, if you will, is something that's rare, but we do see. The reoperation rate here, interesting here, every other procedure that we talked about, you're carving, removing tissue, you're taking things out of the body. This particular procedure, we haven't removed anything. And in not removing any tissue, all we've done is alter the landscape, if you will, of the prostate to allow the prostate tissue to be wider in the middle, but that still doesn't prevent the prostate tissue from being alive and continuing to grow. And so for patients who do have persistent growth of the prostate, that is something that the prostate can continue to grow. And 8, 10 years down the line, you may need another procedure. And so we haven't burned any bridges. We can always go back to the Roto-Rooter if need be, or one of the other procedures. So this is something that you can have a good 8 to 10 years, but for that 15 to 25%, you haven't burned any bridges, we can move on to something else. So what I attempted to do today was to go over a number of different options. We talked about medications to open up the prostate. We talked about old-fashioned surgical procedures where we cut, make incisions to open up the prostate. We've talked about minimally invasive options such as microwave. We talked about green light lasers. We talked about UroLift. We talked about Zoom procedures. These are all procedures that are designed to do one thing, to help you to be able to be better. So the goal that I tell patients, help to find the best way for you to be able to urinate, whether it's through medications, a minimally invasive option, a invasive option, or everything in between. It's not a question of whether or not we can find something that works for you. The question is finding the least invasive option that you feel comfortable with. And with that, I'll go ahead and open up the panel to questions. And if anyone had any questions, we can go ahead and answer them. And that will conclude the presentation for today.
Dr. Alphonse, we want to say thank you. That last photo is quite comical.
But that's the goal.
Effectively done, tastefully done. First of all, we want to say thank you. This has been quite informative. I am not one for anything. It's the terminology Roto-Rooter just kind of strikes me the wrong way. But I do have a couple of questions as a kickstart, and while we're waiting on our online audience to pose their questions, and we're monitoring that, as well as our, for those of you who are on Zoom, we welcome those questions. Go ahead and type your questions there in the chat, whether you're on the live stream or on the Zoom platform. We welcome those questions, and I'm sure Dr. Alphonse will provide you as thorough an answer as possible. You talked about alpha receptors a little bit earlier. What is it that causes the stimulation of those alpha receptors?
Sure. So an interesting thing is, as part of my basic science research when I was in residency, we had to do research in looking at what was so unique, if you will, about the male prostate versus, say, for instance, a bovine prostate, a dog prostate, monkeys, if you will. And the interesting thing is that all prostates have exactly the same type of cell type, which is smooth muscle cells, prostate epithelial cells, and connective tissue. What makes the human prostate a little different is that the percentage, if you will, of the smooth muscle cell component in our prostate is around 62 to 68%. So it's more muscle, if you will, than prostate tissue. And that muscle, just like any other thing in your body, if it gets stimulated, it can contract. And if it contracts, that's what closes down that urinary channel. And that's what causes a lot of the irritative symptoms. So using the same analogy, and I didn't go too much into it, but one of the very first medicines that I showed was something called Cardura. Cardura was actually a high blood pressure medication designed to, it's called an alpha blocker. And what they noticed serendipitously was that when they put patients on Cardura, it was called doxazosin, the generic name, they noticed that patients who were having some urinary challenges dramatically did better. They urinated better, urinated easier. So they took that information and they found that the alpha receptors that you have all throughout your body that we use to block when you're trying to improve high blood pressure, hypertension, that we also have alpha receptors in the prostate that particular medication had a predilection for, or had a target, if you will, to the prostate. And they essentially took the exact same medication that they use for high blood pressure, repackaged it, called it a different name, called it Cardura. And that was one of the very first prostate medicines that we had. The problem with it was the body didn't know that it was supposed to be for prostate versus high blood pressure. And when people started taking that medication, if they took the higher dosages first, it caused them to get a little dizzy because it dropped their blood pressure. And so they found out that they had to actually slowly introduce a 1 milligram version, then a 2 milligram version, then 5, then 7, to get the body to acclimate before you can get them up to that 10 milligram dose. So that was something that we learned, if you will, something called postural hypertension to prevent. But as the medicines got better, you didn't have to do that little stair step, if you will. And now you could just start 1 pill or 2 pills, depending on what it is, to block those alpha receptors and have minimal impact to high blood pressure versus the very first medicine that we had on the market.
Okay, thank you for that. We have a question that just came in that says, what can be done for preventing the enlargement?
Sure. So just having an XY chromosome is, being a man, is the risk factor of prostate enlargement. Does that mean that every single male is going to have that problem? No. However, we do see that there is a certain subset of men who have BPH more so than their counterparts. And as we see, every male, as you get old enough, you are going to have some urination challenges. There really isn't anything that you can, quote unquote, do. There isn't any exercise, if you will, to prevent your prostate from enlarging. The goal is recognizing when those symptoms occur, getting with your doctor to get on some medications to help improve those symptoms. And there are things that are out there that are natural, such as saw palmetto and some of those other things that are out there that can do some of the same things that a lot of the medicines that I talked about today. We have found that a lot of those medications are extremely effective. Some of those medications work by providing, if you will, an estrogen therapy. So the prostate, it grows because of testosterone. So saw palmetto has an estrogen-like effect where it actually blocks the testosterone from stimulating the prostate from growing. And so some people who are on saw palmetto can get the estrogen-like effect, such as breast enlargement and some of those other things. So those are things for you to be cognizant about, that every medication, whether you get it from a physician or if you get it from Whole Foods, has pluses and minuses associated with it.
Wow. There is a question that just came in. Actually, we've got two, so I'm going to go to the first one. It is said that some people believe that a lot of ejaculations increases the risk of prostate cancer. Is that true?
That is not true. Prostate cancer in and of itself is a dysfunction of the prostate cells, just like you get a dysfunction in the breast and you can get into breast cancer. You can get dysfunction in the prostate and those cells abnormally grow and you can get prostate cancer. Now, there is a genetic component to prostate cancer where we have seen that patients who come from family members who have a history of prostate cancer are at a higher predilection for prostate cancer. And patients who come from an African-American descent, we do see that in our community, it is something that prostate cancer affects us at a higher clip than our Caucasian counterparts. So there are some genetic factors associated with prostate cancer. Ejaculation is not one of them.
Okay. The next question is there for Black men, since we have a higher risk of prostate cancer, is that the same as an enlarged prostate?
So the risk factors for prostate cancer is race specific. The risk factors for an enlarged prostate, benign prostate enlargement, we do not see that tends to be race specific. I do see plenty of Caucasians in my clinic who come in with symptoms associated with benign prostate hypertrophy. And I'm seeing younger and younger guys come in with BPH-like symptoms. But it's not because of what you would think. It is because they are using over-the-counter testosterone supplementation. And if you remember me saying before that testosterone is like the food, if you will, for the prostate, if these are guys that are using testosterone to help bulk up in the gym or give them zip and zazz, over the course of the day, that is something that can also stimulate growth of your prostate and give you some urinary challenges. So I do see a lot of men in the early 40s that tend to be testosterone supplementation related BPH problems.
Okay. All right. Next question is when does a man realize that his urine flow is lower for him to consider getting medical advice, especially when Black men on average visit doctors less often than other groups?
Right. So you're asking a very, very, very great question. That is going to be a different answer for different people, but I'm going to tell you what I tell people. If your wife starts to mention, hey, you're going to the bathroom frequently, why are you going to the bathroom again? If your friends start to tease you about, hey man, do we need to stop the car because you need to use the bathroom very frequently? Or if you're in the golf course, pick another partner, if you will, because they know if they pick you as a partner, you're going to slow them up because you're going to be running around looking for a bathroom. People tend to know your habits a little bit better than you do because you have become accustomed to it. You have become acclimated. It's become your new normal that you don't realize that you're ripping and running to the bathroom every 30 to 45 minutes. But people who don't have that problem do realize it. And they're one of the first people to kind of let you know. Another symptom is when you're walking into a building, whether it's a restaurant or you're going into Walmart or whatever, and one of the first things that you do is you make a mental note where the bathrooms are, because you're already strategizing, if you will, that when that sensation comes, you have about a few short minutes and you don't want to play around with trying to figure out where that bathroom is, and you want to get there as quickly as possible. So hyper awareness of where restrooms are in public places is another symptom that you do have some prostate issues that are going on. And then all the other things that we talked about previously in terms of frequency, urgency, sensation of incomplete bladder emptying, getting up 2 to 3 times at night, those are all symptoms of something going on.
Okay, all right. Next question that I have for you is in relation to this timeline on the, once the procedure is done, regardless of which tract it is, the regrowth of the obstruction. How just kind of give us some insight there.
Yeah. So the regrowth of the prostate is truly going to be predetermined on which procedure you do. If you do the Roto-Rooter, I know you don't like that word, but it's very descriptive. If you do the Roto-Rooter, you have a lot of tissue that's removed, and the likelihood of that tissue or the timeline for that tissue to regrow enough to cause similar symptoms in terms of the obstruction is going to take a while. And most patients, we're talking about 85% of patients, when they have the TURP done, that's a one-time procedure and it's over and done with. But 15% of people, because of just having a big prostate or a prostate that's very sensitive to hormone manipulations, if you will, and can cause some growing of the tissue, that can cause regrowth. And when those symptoms reoccur, the same evaluation that I did the first time, ultrasounds, cameras, cystoscopes, questionnaires, so on and so forth, that's what helps me to figure out if the issues have recurred, and then for us to come up with a disposition on what we need to do to get you taken care of again.
All right. We have another question that just came in that says, after having a TURP 10 years passed, he said, is it normal to have passing a centimeter of blood once and sometimes twice per month?
So having blood is extremely common immediately after the procedure. I would say that once you get past 6 months, that is something that is rare, you should not see. Now, the caveat is if that person is on blood thinners and things of that nature, it does kind of double, if you will, the healing time. And so all the numbers that I originally gave you in terms of when you should expect the healing process and things to kind of settle down, just multiply times 2 for someone who's on a blood thinner. But if you are at years, 2, 3, 4, 5 years out, and you're having blood in your urine from time to time, that's abnormal, and that is something that should be evaluated.
Okay, thank you for that. We've got about, looks like we've got 3 additional questions here that are coming up as you are providing your answers. So that's very good. Again, we'd like to thank everyone for tuning in and for providing your questions. The next question is coming. It says, at what age should men get tested for prostate cancer, even if asymptomatic?
So in our community, it is appropriate after age 40. On your 40th birthday, when I'm going around doing these lectures to churches and stuff like that, I tell guys, on your birthday, you need to be in a urologist's office getting your exam. And then you can go home and eat your cake. But the prostate exam is important. It is a combination of blood work and the rectal exam. But this is something that I think men, we're getting better at. As the health disparities and inequities the gap is closing, we are doing more in terms of preventative care. We're doing much more preemptive, if you will, evaluations to our doctors. So we're getting better. We're not where we were back in the 50s and 60s, but I think that our message is getting out there, and it is not taboo, if you will, for a Black man to go see his urologist. And if anything, it's highly regarded and something that's deemed positive, because this is something that we're really getting the message out and people realize it's something very important. If you have a family history of prostate cancer, it's 35. 35 is when you start getting annual rectal and blood work exam. No family history, age 40 for African Americans.
All right. Does it matter how large the prostate is before sex? And if so, Why the urgency to detect?
So that's a little confusing. I didn't understand that question. I can't come up with a scenario on how one would be able to tell if their prostate is enlarged prior to intercourse. That person's going to have to kind of resubmit that question. Unless maybe you can kind of give me a different angle.
I'm not going to call his name, but you've heard.
Just ask him to resubmit. Ask him to resubmit.
Yeah, just please rephrase your question, provided in such a way that we can get a little bit more
clarity on that.
Yeah, a little bit more clarity. All right, so we'll skip to the next question. It says, do all insurances cover some of these treatments? What if you do not have medical insurance and you get treated through Obamacare?
Yeah, so indeed, I would have to say 85 to 90% of everything that I talked about today is covered by most commercial carriers. There are some newer procedures that I didn't even kind of go over because these are things that just probably came out in the last maybe year or so. So it's still deemed investigational by a number of the carriers. And so it's not available for public consumption, if you will, on all the carriers. But if Medicare covers it, then usually the commercials follow suit. So I would have to say 90% of the time, whatever you want will be covered. If you're on Obamacare, it will be covered.
All right. And there was clarification. Thank you, my brother, for doing so. He said that his question was, does it matter how large the prostate before surgery? And if so, why the urgency to detect?
Got it. So, yes, knowing the size of the prostate is extremely important. There are certain limitations that some of these procedures have where they're ideal for prostates that are of certain size, 30 to 50 cc's. Some of these procedures are not appropriate for prostates that are greater than 100 cc's. And in fact, the open prostate procedure is more appropriate for prostates that are greater than 150 cc's. And so whenever a patient is coming in with urinary issues and so on and so forth, as part of the workup, when I do a cystoscope or that camera and I look inside the urinary channel, I'm looking to get a gestalt, if you will, of the size of the prostate. And if I can't get a rough guesstimation, then I'll get something like an ultrasound or a CT to get me the exact measurements, because that can determine if we go down the left path or the right path in terms of certain treatment alternatives.
Excellent. All right. We have another question. What is preventive care, as you alluded to?
Sure. So my definition of preventative care is knowledge education. Getting into your primary care physician or getting into your urologist on an annual basis after the appropriate 40 years of age or 35 if you have a family history, that is your preventative care. You know, it's the same analogy that I use for someone who has a car, listening to that light that's on the dashboard, getting that light checked out and seeing what the etiology or the cause of that light being. So it's the same thing that when you are seeing your primary care physician or you're seeing the urologist and you're having some frequency and urgency and getting up 3 and 4 times at night, that's your check engine light that your body's trying to tell you that something's off. And that is your cue to get some assistance.
All right. And we have one more question that says, with many female-headed households, many young men may not know the health history of men in their family lineage. So how will they know if they have a higher propensity for BPH or prostate cancer?
Yeah, great question. In that scenario, clearly, if the father is not available to be able to provide that information and the mother is unaware of the family history of the father in question, then it behooves that person, age 40, getting in with their primary care physician, getting in with the urologist, getting in sooner if you're having symptoms, if you're having problems. Don't discount that, it's just probably gas, or, it's probably just stress. No, your body's letting you know. If something's amiss, if something's off, your body's letting you know. And that's why those symptoms are occurring.
So I think one of the big deterrents for most men, and I'm speaking from a personal standpoint, I'm sure you can identify with this, is it seems like the old method is still tried and true, the digital exam. Tell me that with all of the technology that you have, the STEAM and all of these newer technologies, is that still the true to form? Is that the only way? Or I heard that there was a blood test that could be done.
Sure.
So you didn't have to go through that anymore. Enlighten us, if you will.
So this is what I tell my patients, is that when it comes to prostate cancer, I'm talking about here in the United States, we are able to identify prostate cancer practically in its infancy because we have access to medical care that people around the rest of the world don't have. If you have an issue or a problem, you can go to the emergency room with or without insurance. They are obligated to see you, and they will see you. Now, PSA is a blood test that lets us know when something is awry, something is not normal within the prostate. It is not a fail-safe indicator of when somebody does or does not have prostate cancer. If you have an infection in your prostate, your PSA can be elevated. If you have benign prostate hypertrophy or prostate enlargement, your PSA can be elevated. Prostate cancer, your PSA can be elevated. Prostate irritation, meaning precancerous cells within the prostate, your PSA can be elevated. So the PSA in and of itself does not say yay or nay that something's going on. And that's only about 70% of the time. So that means 30% of the time, you can have a perfectly normal PSA, but if I did not do a rectal exam on you and feel a lump or a bump in your prostate, I would completely miss what we call the low grade or really low stage prostate cancers. So we do see patients who can have prostate cancer with a normal rectal exam, but a high PSA. That happens about 70% of the time. 30% of the time, you have a perfectly normal PSA, but if I feel your rectal exam, I'll feel a lump or a bump. So to get that 70 and that 30 to get 100% coverage, that's why we do the blood test and the rectal exam, because we never know which patients are the ones that we're going to miss by doing one or the other. So we do both.
All right. We had one more question that just came in that asked, why more frequency at night?
Sure. And I do think a lot of the irritation with urinary frequency so urinary frequency can be a bothersome issue both daytime and nighttime. However, I do see that there tends to be a higher frequency of getting up nighttime urinating, whether that's due to people who drink tea at night, and tea can have caffeine. Caffeine is an irritant to the bladder and to the prostate, can make you go to the restroom frequently. Sometimes people drink late at night before they go to bed, trying to catch up their water intake over the course of the day. That can cause them to get up multiple times at night. And there's a whole host of issues, such as certain hormones that's produced called the ADH, or the Antidiuretic Hormone. And that is something that normally is supposed to be produced to prevent you from getting up. But for some people, if that hormone is not produced adequately, it can make you go to the restroom very frequently at night. So there's a whole bunch of different testing and things that we need to do to identify if a person is getting up multiple times at night. Is it the prostate? Is it behavioral modifications that need to be done? Is it a hormonal imbalance? So there's a number of things that sometimes we need to figure out.
All right, thank you so much, Dr. Alphonse. We appreciate you taking the time and answering our questions. It looks like we did have one more question. Okay, the question is, when is the last time you should drink before going to bed?
So what I tell patients is it is appropriate for you to hydrate. You ideally need at least 2 liters of intake over the course of a 24-hour period. Now, you drinking 1 cup of water and then drinking that 1.5 liters 10 minutes before you're supposed to go to bed is not going to be a good recipe, if you will, for having a restful night. So I tell people to really get that 2 liters of fluid, equitably distribute how much you take in over the course of the day, but definitely at night before you go to sleep, ideally an hour before you're supposed to go to sleep, cut off all your water intake. By cutting off that water intake, your kidneys will not have to, quote unquote, keep the light on to keep processing all that fluid to try to get it out. So you're relatively a little dehydrated, if you will, before you go to sleep, so you can get some restful sleep. We're not talking about dehydrating yourself over the course of the day, just 1 hour before you go to sleep. So that is an appropriate way for you to kind of get your water intake over the course of the day.
Excellent. Well, Dr. Alphonse, we want to say thank you for taking the time to be with us this afternoon. I'm sure all of those who are on the line, whether on our YouTube channel or either here on the Zoom platform, have been very, very much informed. We're so very grateful for all of the information that you've shared. I was going to add, so I'm grateful that you've already put it up on the screen. For those of you who are watching, you can have contact with Dr. Alphonse, his contact information, his office location there in Marietta on 3747 Roswell Road. His contact information is also there on the screen. So again, we say thank you for taking the time and the presentation. Thank you so much for sharing that with us. It was very well put together. Dr. Hurst has given her kudos there in the chat. I'm sure you can see that as well. But we thank you again. And for all of those who have tuned in, again, we want to remind you that we do have our next installment of our Life Enrichment series. It'll be taking place on next Saturday evening at afternoon at 5 p.m. Pastor, do you want to tune in here, jump on in and share a few things with us as well? Again, Dr. Alphonse, we just want to say thank you so much. You've done a phenomenal job of enlightening us, educating us this afternoon, and we are truly appreciative.
Pleasure's all mine.
Thank you, Dr. Alphonse, for that wonderful presentation, very informative, and we just thank you for coming on here today and really for sacrificing probably everybody doesn't know, but Dr. Alphonse just returned from Africa this afternoon at 12 p.m. Eastern Standard Time. And he's here on the line with us instead of sleeping and catching up on his rest. So we just thank you for your sacrifice and for this tremendous presentation. And Mike, may God continue to bless you.
Thank you. He has every day.
Amen. Amen. I just want to kind of piggyback on what Elder Watkins was sharing, that we have our Let's Talk Life Enrichment Series installment next Saturday afternoon, 5 p.m. Eastern Standard Time on these same YouTube, Facebook stations. We have Pastor Randy Maxwell. He is an author. and a pastor. He's pastoring in the Seattle, Washington area, and he will be on sharing a presentation, Revival of One, Igniting Your Prayer Life. And so he will be going through various things that you can do just to jumpstart your prayer life and take your prayer life to the next level. So you cannot afford to miss this next Saturday afternoon. For those of you who may not be familiar with this, or you're just being introduced to us, we do this once a month, and you just can't afford to miss our Life Enrichment series next Saturday afternoon, October 23rd, at 5 p.m. Eastern Standard Time. Also, Pastor Maxwell will be speaking for our 11 o'clock service next Saturday at 11 a.m. again on YouTube, the Ebenezer Productions, on Facebook Live at EBNZRSDAAUG. And I know that you'll be richly blessed by his presentation. I just want to thank our health and temperance leader, Dr. LaShonda Hurst, and her team for their tremendous work and for just conceptualizing this and the vision for this program this afternoon. So thank you all for joining. We know that you were blessed. And I just want to close with a word of prayer this afternoon. Dear Heavenly Father, we thank you so much for what we have learned and the information that we have gathered this afternoon. We just ask that you will continue to bless us. May we, if we are experiencing warning signs, may we take the appropriate action, Father. And we just ask for your blessings in our life and for continued good health. Father, bless each and every person that tuned in this afternoon. And Father, as we move throughout this pandemic, we ask that for your health and safety. And we thank you for your watch, care, and protection in our life. In Jesus' name, amen. Thank you once again for joining us. Thank you to our panel. And we look forward to seeing you next Saturday morning, 11 o'clock Eastern Standard Time, 11 o'clock a.m. Eastern Standard Time, and for our Let's Talk Life Enrichment series with Pastor Randy Maxwell next Saturday, October 23rd, 5 p.m. Eastern Standard Time. God bless you.